So many questions. It's a hard way to start. But I think one of the themes, certainly, of this gathering on the cardiovascular and between cardiovascular and radiology and lung cancer and lung disease experts is, how do we be more intentional rather than just opportunistic about looking for heart disease and lung disease together? I guess one of the questions that also I don't think was quite touched on, but when we were talking earlier about the frequency of lung cancer screening, we don't typically think of coronary calcium scanning, particularly, if you're using the power of 0. I mean, the data has varied dependent on sex and race as to how frequently to look again, but it's often sort of 3 to 5 year time period. And so I'd like some perspectives on this idea of, do we try to do a combined scan, or do we have sort of a primary focus and at that particular time, and even think the downside of doing the 2 separate scans so that we have the data sort of as planned, and sort of the pros and cons of doing that. And so, yes, maybe, sure.
I think we can start right now with looking at coronary calcium on any chest CT, including chest CT screening. If it is high in a visual way, you're pretty sure it's elevated. So that's reassuring. You do miss cases, and you have to be aware of that. Because of motion, you'll underestimate the presence of calcium, but that's not really, I think, the issue in the screening cohort at this moment. And you will underestimate some people who have a high calcium score. But you can do this like from right now. And actually in the I think the Manchester cohort screening, they already implemented a similar intervention.
I guess this raises sort of the calcium of 0 power if you're uncertain whether there's mild coronary calcification from, a chest CT that's geared more towards lung cancer screening. And I know Matt and I, we were talking on the Uber over here that a lot of radiologists sometimes think, is there any point in talking about seeing mild coronary calcium, or if you're going to miss some mild coronary calcium? But as Dr. Marin and I, and I'm sure Karim, your practice too, there are many patients where any coronary calcium becomes an indication for a shared decision around preventive therapy. So I naturally worry about missing the mild and not having a true power of 0 if you're very uncertain, unless it's either high coronary calcium or not. So
my thing is, let's not have perfection be the enemy of good. I think so a simple non-gated, non-contrast CT suffice, especially if the population is going to be elderly most of the time, 65 and above. And we know that in that population, even a calcium score of 1 to 10 may be sufficiently powerful in ruling out risk in short, intermediate term. So in that scan, I think the opportunity to combine them outweighs than the potential risk of missing the very few. And visually, any calcification should be a rationale for initiating at least the primary prevention for statin LDL lowering. And unless and until you have significant disease, which is very unlikely to be missed on a non-gated scan, where you're going to intensify therapies with more advanced treatments, including aspirin, I think that this combination, and if it can lead to mass screening, and from a cardiology standpoint, I want to leverage of what already is happening, where we have huge challenges in getting the calcium testing. And I'm saying, let's piggy bank on this initiative that's happening, and we should go with it. And yes, in cases for severe hyperlipidemia or diabetes, where Mike, you want to be more sure, add another calcium test. But I personally think that it's not going to add significant value. The value may be by an inch rather than a mile.
I think we have 2 Davids with microphones.
just talking about how to design the right protocol. One of the things that he had suggested, and I think it's really interesting, was that he said, on those patients, if you're doing a non-gated scan, the one he's interested in is the 0. And he said, if you have a 0, maybe that's when you should get a repeat scan and prove that it's really a 0. That was one of his suggestions. And just the other minor part to this that maybe you'll comment on is, with these newer scanners, the thinner sections, the zeros we're finding more So I've never understood why we haven't gone to the thinner sections. I see it all the time, a CAC 0, that when you look at thinner sections, you're seeing calcium. So those are the 2 points.
Yeah, but we published that already in Radiology 2003 with EBT. I mean, that's obvious, right? You have less partial volume effect.
Yeah.
So, but I think when we look at the recommendations from guidelines, the calcium score above 100 is the one that is decisive for management. And so, of course, if you're in a cardiology practice and you want to, or you have a patient with maybe some chest pain and you want to rule out coronary disease, I think there's also very strong data from Florida there. Then you want to be absolutely sure that the calcium score 0 is 0. But in a screening setting, I think we need to look at the high calcium score for management. And I think that comes back also to the point yesterday about a primary care physician doesn't want to know mild calcium. What do you do with mild calcium? Nothing,
So-
right?
So
We do a lot with mild calcium, but it depends. We do a lot with mild calcium. It very much depends on age and other risk factors. It's a key part of our decision-making and prevention. So I would strongly not discount mild calcium, but it's in the context of the individual patient.
So
Um,
I can two parts of that. One, Jagat and I can discuss this a little bit more. And again, the value is, yeah, you may have to do at least 100 scans on top of a normal non-gated CT to capture 5. And that's fine. Look, we don't have infinite resources as a population, as a society. And yes, at some point we'll have to draw a line where the value is. I just don't see significant value yet. Now, regarding the mild calcification, if you look at the guidelines, truly what they're suggesting, if your 10-year risk is around 7.5%, you should be at least on a statin. And data from all the cohorts have clearly suggested any calcification pushes you above that threshold. So I think it's time for the next cholesterol management guidelines where they're trying to put too many people on statins, but when any plaque mild, they are uncertain. And I'm saying that doesn't make any sense. To simplify, calcium 0 flexibility, any calcification, statin, calcium more than 100, treat them as established cardiovascular disease, high intensity statin, aspirin, and other cardiometabolic therapies. I think so that's the direction that we need to head. And I personally think we're getting there. And as you know, the new cholesterol management guideline, the committee, they have already started. I hope they can take into account all the newer data that has come over the last 5 years to simplify it for the primary care and other folks who are uncertain about the mild calcification.
And
Yeah.
yes, Dr. Avila.
Yeah, I just want to just point out that our scanners and our software are highly unoptimized. As we've seen in the Kiba small lung nodule profile, after how many years, 20-something years of work, what we've done is we put phantoms all across the world, ultra low-cost phantoms, and we've collected massive amounts of data on how people are screening, especially when they optimize their protocol according to first principles. First principles meaning resolution, noise, sampling rate. And when I say resolution, I don't mean 2D resolution. I mean 3-dimensional resolution. So we have a massive database. We have of what's happening across the world. And if we want to answer the question, how well can we detect a small calcified object? For example, is this a 0 or is it not? I would go to that database and modeling simulation and ask the question there. And then also use those sites with the calibration phantoms to figure out what the trade-offs really are out in the field. Because I feel we're throwing around concepts and ideas and not going back to first principles and data. And I-ELCAP has always been about massive data and first principles.
Yes, in the back. Yeah.
is that it's really time for the vendors of CT machines to increase what the daily expectation is of calibration of machines. It's one thing if we're just looking at pictures. It's another thing if we're measuring information in images. And it's critically important. Every day we start up the scanners, we do daily calibration, not getting to the kind of detail that Rick is talking about that is so necessary in the quantitative imaging field. So for any of you CT vendors who are in the room or online, I think we really need to change the paradigm for calibration. But I 100% agree with where you're coming from, Dr. Nasir. I love your approach to coronary calcium CT. And I only hope that we can disseminate this information to people to put in practice, because people are struggling with what to do, how to do it, and when to use this information. Even our preventive cardiologists, where we're going to start to do the quantitative scores on the lung screening CT, are like, oh my goodness, we're going to be overwhelmed with patients. Primary care is not going to know what to do. So when I put my clinical operations hat in the medical center on, I'm like, okay, well, it's great that we can do this in radiology, but we need to prepare primary care, and we need to prepare preventive cardiology for what's going to come with it so that we can get the power out of this
So
information.
I just want to add, it's as simple as getting the message: see disease, treat disease. Greater the disease, more intense the treatment. That's it. It's truly as simple as that. And we don't have to complicate it and say, you see disease, you start the treatment. And if you have more disease, you be more intense. That's it. And hopefully.
It is in the guidelines. We can circulate.
Not
I meant to
explicit.
Primary care, yeah.
Yeah,
We should show that figure, David.
yes.
Go ahead, Jim.
Yeah, hi. This is the best session on cardiac imaging in screening that's ever happened in the history of the world. Oh, okay, Dr. Shemesh, please, just one or two. To come back to what Ella was saying, we're drawing distinctions between visualization and quantitation. And those two buckets are really different. They're complementary, but they're different. And we have to reconcile when we're talking about one versus when we're talking about the other, because they've been conflated many times in this session as well as previously. The other thing is we've got to delineate screening versus medical imaging. In the screening setting, it's about harms and benefit in a very carefully calibrated way. And it's not about diagnosis. It's about understanding risk and kind of managing risk. And so when we do that, perfect is not what we're looking for. And the point of screening is not screening. The point of screening is mortality reduction. So we're looking at events that lead to premature death. And so when we start deconvoluting, deconstructing all that's been said and putting in the right context, it becomes a much simpler matrix, as you are suggesting. And I think that's what we got to do. So we're doing this right now for coronary calcium. Let me tell you, we could have the same darn session about density measurement of emphysema, and it's the exact same issues. And if we want to solve this first and then move on to emphysema, then move on to bone density, we're going to be into the next century. We've got to understand that there's some process issues here about quantitation in the screening context that kind of generalize in ways that allow GE and Siemens and Toshiba and everybody else not to go crazy. It's going to be an issue they're going to be seeing again and again and again when they start looking at early disease in a preventative context. And it's spectacular, because if we get this right, we're going to save a lot of lives.
Yes.
Yes.
When I try to study this literature, all of this information is usually coming from the general. And people will read for lung cancer screening or heavies. They may have quit smoking a year ago, 2 years ago, but they have 40, 50 years of heavies. And is it true that zero calcium in such smokers means the same as zero calcium in a never smoker in the general population. And along the same lines, what we are finding is that the distribution of calcium scores in our female veterans in the VA system is very, very different than the distribution in the group of male veterans in the VA system. So is the meaning of a zero or low calcium in female veterans the same as in male veterans?
So great question. So two parts. One is zero calcium has the same relative risk as a smoker versus non-smoker. Answer is no. The smokers are at a heightened relative risk, but their absolute risk is still pretty low. And by the way, we have to think about the biological processes. It's not truly in smokers who continue to smoke. It's not only atherosclerosis, but more thrombogenic. So the processes may be different. So yes, smoking cessation, possibly antithrombotic may be a consideration, but the relative risk is higher, but the absolute risk is still below 5% 10-year risk, where the guideline says you don't even need to think about statin. I'm not saying you shouldn't. That should be a shared decision-making. Now, the good part of calcium testing is it doesn't really discriminate based on your age, race, or gender. If you have a calcium score of 0, again and again, it's shown whether you're an African-American, Hispanic, white, South Asian, the risk is almost the similar, whether you're 45, 75, for the same amount of plaque, your risk is the same, whether you're male and female. So basically, it overcomes all the fallacies that we are going to assume based on your risk factors, your biomarkers, your demographics. A simple test, $50 to $70, widely available, radiation equal to a mammogram. You can even take a van and get it done. And I'm saying, why are we guesstimating?
Yes, Dr. Schmesh.
First, as for the 100 calcium score, it is not a cut point of treatment or not. The 100 come from the data that shows that whenever you have, most of the people who have more than 100 have a risk, 10-year risk of more than 7.5. It means to say that it should be treated. Now, I would like to say to the radiologist, first of all, as for the zero calcium score, please put 1 sentence. There is no calcium in the city. Whenever you say it, first of all, you give us the huge, important information that there is zero calcium score. Second, when you are doing the radiologist or the ordinal score, visual score, it just gives you an idea for the clinician where you are, if it is 0, mild, moderate, or severe. Now, if you want to translate it to treatment indication, this is not enough. You have to go to the MESA risk, you have to go to the PCA risk, which take in consideration all the clinical picture of the patient, and now we have data on this. We have 4 categories of up to 5. Person who have, even if you have, he might have 150 Hounsfield, but his score might be less than 5%. Then the guideline tell you that in some setting, you don't treat him. Or, so what I'm trying to say that is, if somebody want to translate it really for the treatment, it should be, it means to say the cardiologist or the physician, he must go to the MESA or the PCE, how do you call it, stratification to about the treatment. We are not treating just because somebody have above 100. This is not, so the conclusion from this is that it's not very important if the calcium score is 90 or 120. At least when you put it in the MESA risk or the PC, it doesn't going to change the category, okay? Because to changing category, you have really need very big differences in the amount of calcium.
So can I
Okay.
just give you a little bit of my differing view on this, and is that when you use the PCE MESA risk score with the calcium, it is only for CHD, it's not completely for CVD. And the reason calcium score of 100 is a great cutoff because, again, it's an exponential. And after that, universally, the risk is not just 7.5%, but across the board, we and others have shown it's about 20% 10-year risk. And if you have any calcium, I have hardly seen that the risk not going up. And the PCA, that's why we don't use that more often, because if you look at any calcification, even 5, 10, 15, depending upon which age group, it pushes your risk above 7.5%. So that's why I'm advocating for a very simplified approach. If you have any calcification, your risk is already 7.5%. Shared decision-making status. Once you get above 100, it doesn't matter what age, what risk. Your average risk is 20% or more. So they should be treated as somebody like a CVD equivalent. So if we can simplify that, it becomes much easier rather than trying to decipher with multiple calculators, which doesn't make much sense.
One more question.
This, I think the summary that Khurram just made with also his presentation on CCTA. As you guys have seen, the lung cancer community are not very familiar with CCTA being pushed to the front line as a screening. And of course, wealthy people are worried, well, can go and get it. I have no problem with that. We should, we'll leave it to them. It's their choice. I've done it myself. So if it's guilty, I've done it myself. But we're here for a societal population level proposal where we want to take it to the masses, millions. I showed you 37 to 40 million people. That's why I totally agree with Khurram that we should do what we have in front of us. We don't need to do, we will do a study comparing the jagged approach. If it's 0, do another one, and then we compare. But I think we have now new technologies that have not been quite tested. For example, applying AI. I haven't shared with Khurram yet, but we looked at MESA CAC 0. We found some CAC. Those are not 0. So that's more power to power 0 because those people who had events. We actually looked at people who had events in MESA and their CAC 0. And we found CAC with our approach, with our AI. So that gives more power to power of 0. Then we could do things that Rick has been advocating for like forever and bring to realistic use. Again, it's not costly. It's a pretty simple device. It just improves the accuracy and resolution and energy and all those things, basic physics that these guys know very well. So without making a massive change, without bringing a photo counting CT or anything like super sophisticated, we can advance, as Jim said, our goal is not a screening, our goal is saving lives, reducing mortality. We can advance the field by putting into work, and the concerns that Rosemary just alluded to, misclassifications, I think we should do a study comparing. Here is the 1,000 cases of gated, non-gated with Rick Avila device in there, and then with extra AI addition that we can add with thin slices that here, and see how much really need there is to go. And if it is 100 to get 5, maybe it's not worth it. But if it says 100 to get 60, then it's significantly adding value. So back to you, Mike.
Now,
Yeah,
I
go ahead.
completely agree. If we want to have global implementation of lung cancer screening, you don't want a high-end scanner. You want a robust, run-of-the-mill scanner that is standardized enough to have sufficiently accurate evaluation of the markers you want to predict.
Box on their machine that doesn't need to be $1 million. It can do the same result.
Yeah, let me just throw out an example that most people aren't aware of. When you get a CT scan, on some scanners, you're going to get a rectangle as a slice. It's going to be nice and flat all the way across. Our friends at Siemens actually do quite well in that regard. But on other scanners, you sometimes get a concave, like imagine a concave symmetric object. So it's nice and thin at the center, and then it's really fat and big out at the edges. So now what are you gonna do? You're gonna try and stack these things, right? For a lung screen, you're gonna stack them. Now, most people aren't gonna stack them at the center. They're gonna stack them 100 millimeters out usually. So what you're gonna wind up with is a gap, a small gap. Now, is it a 100% gap? No, it's a lessened, let's say, ability to detect what's in that space. And what I'm getting at is when we talk about scanners, they're not all the same. And the protocols are not all the same. The recon kernels are not all the same. The only way to absolutely know what you really got is to put a phantom in there. And yes, we've been working very hard for 20 years to make these things available.
Which can be done on any scanner.
On any scanner.
It
But-
doesn't need to be modeled like, 250 fixes line.
Right. And we can identify the scanners and protocols that might produce a gap and might cause you to get a different coronary calcium score when you just change the position of the patient. Now, let me add one more thing. What we do, we calculate at very high precision the three-dimensional resolution of the scanner. That's a spatial resolution. But in cardiac, we have a time dimension. And we need to know the time resolution as well. So we're hard at work right now trying to come up with an extremely low-cost way of not getting a three-dimensional resolution, but a four-dimensional resolution, 3D plus time. And I won't go into the, all the math and physics of this, but if we had that information at every position in the scanner field of view, then we could really tell you what this thing can do. And there'll be some challenges along the way, but just like before, I have no doubt we can do it.
So Rick, why couldn't we put in a table phantom that every CT screening facility has in the table itself? So you get it with the image.
We have tested CT table phantoms. They're very good at even our prototypes, which we've gotten down to 11 millimeters thick, just added to the table. Every scan and almost every slice, we can give you what's going on. But that's at a certain distance from isocenter. So you'll always use a standard phantom and a table phantom, and you'll get wonderful data for every scan. However, if we want that four-dimensional resolution for cardiac, we're going to have to put another device in there. And I'm hoping we can bring that in under like $100 or $200. That's the goal.
We just have another question from Dr. Ramirez-Giraldo.
Yes, son. Maybe to elaborate on that, because I very much agree with Rick that there is a tremendous opportunity to make more uniform use of protocols that are appropriate. But I wanted to bring attention also to that the coronary artery calcium, if we want to do it really quantitative in these CT machines that are, and also at the same time, really cover the right inhomogeneity of systems that are, again, because this is more of a population type of initiative. The requirements for cardiac CT are considerably higher than for lung cancer screening, I'm afraid. I totally agree that doing a measurement of temporal resolution is going to be key, but it might be insufficient really to have a good program. So maybe I don't know if this will be provocative, but I do not believe that it's possible to quantify calcium score without gating, at least to the level that we are used to traditionally. I think that being presence or no presence, some good quantification of higher values is possible. But when you technically, at least when if there is motion, a lot of those values you're going to see a lot of zeros, and you might not be able to also quantify half quantities. So maybe a different metric is needed. Maybe some efforts like the small lung nodule, but something alike for what can be done with calcium. What would be that new metric of calcification? What would be the error bars? But I think that quantifying as we normally do it today with calcium score might not work the same way.
I can say that Yes, there are differences, but really not meaningful. Yeah, you may get a calcium score, and Dr. Meriden and their group has done with AI on the non-contrast. It's kind of pretty good in the sense the calcium score may be 15 versus 21 or 120 versus 130. But in the end, that's not going to meaningfully impact in what we do with those patients. As far as zero is concerned, I think so there is a ton of literature that have shown clearly that the misses are not that much. I would say 5 to 6% range top most. So I agree, if we truly are interested in deep quantification, we may need some more modification. But as I said, it's not going to add much value to what we want.
Just one quick comment. I think for state-of-the-art systems, I do agree those numbers are going to overlap. But again, I go back, this is population based. We're talking about scanner 10 years old, 5 years old, maybe entry-level systems. So in those, at closer to zero, the error bars are going to be very large. So again, it's more a matter of if we are really want to quantify. But it doesn't mean that the stratification would be helpful. For sure, it would be a more discrete type of classification, like the mild, moderate, severe that was mentioned earlier. Absolutely, I think that should be totally possible.
Yeah, David, be great to hear your question, but also if you could comment on your experience with AI and on calcium scoring.
Sure. Well, that was going to be actually part of my question. Several years ago, in the preventive, so I'm a cardiologist, in a preventive cardiology clinic, we order a lot of coronary calcium scans. And before ordering a scan, we learned, well, let's see in the radiology folder if the patient's already had a chest CT for some reason. We can answer the question without exposing them to the extra tests, the radiation, the cost, the inconvenience. And the reason that we try to do that is, for one, we're trying to save patients cost, because insurance companies don't pay for coronary calcium scanning. Why don't they pay for coronary calcium scanning? Because there's never been a clinical trial to prove that screening for coronary calcium improves prognosis. And so then I got stuck on a mission to try to design such a trial and realized that there are millions of people out there who have already had a coronary calcium documented on a non-gated chest CT that was done for other reasons. So maybe we could, in a cost-efficient and time-efficient way, identify a large cohort of people with coronary calcium who could serve as a cohort for a clinical trial. And then the logical thing is, okay, well, we're not going to manually look at all those CT scans that are in a PAC system. We should develop an AI algorithm to read the coronary calcium and identify a cohort with a score greater than 100. So we developed a deep learning algorithm. There are several companies that have AI algorithms to score coronary calcium. And the innocent question I was going to ask, or maybe the upsetting question is the future for CT manufacturers to build that in, or is it just an add-on algorithm that is part of the post-processing, no matter what the scanner is, to do coronary calcium? Because I don't think, like others have said, that you need to really worry about changing the way low-dose CT is performed to look for lung cancer. You can add, with pretty high fidelity, one of the algorithms that's already out there to get a calcium score.
Well,
Maybe
Siemens has something
I
like
can-
that. But
Yeah, we have software already to do that. So, for example, we have something called the chest AI rad companion. So you can actually, in a regular chest CT examination, actually get a quantification of calcium. Again, to my earlier point, it's not an Agatston score, but you can do a quantification of the calcium. So some of those features, I presume other vendors will be integrating as well. And I guess they're probably going to be a universe in which is part of the scanner, maybe it's part of post-processing software. But yeah, I don't know if maybe you sound like you have some experience.
yeah, we used it in our population imaging study. I think what is important, and there have been some intervention studies in the US, that if you include the calcium calcium amount in your conclusion, for example, for any chest CT, a lot of the referring physicians could be, pulmonologist, rheumatologist, any kind of doctor. They need to know what to do next because they're gonna be faced with this recommendation, but it's not they're not the one looking for the cardiovascular risk factors or whatever. So we need really good management and feedback so that these patients end up in the right physician to check their cardiovascular risk.
Yeah, totally agree. And I think that you'll be seeing publications and guidelines that help guide primary care physicians and cardiologists how to manage a calcium score. But it's unethical, and we'll, I guess, be talking about ethics later today. It's unethical not to inform the physician and especially the patient about the presence of coronary calcium, because a calcium score greater than 0 carries a lot of important prognostic information.
While you're there, can you tell us what you found in your study? Or...
If time
Yeah.
permits. Okay, so yeah, so what we did is in order to plan a large clinical trial, you need to get an idea of what is the effect size of the intervention, so you can calculate how large population you need for a clinical trial. And what we decided to do was to, instead of randomly assigning people with a calcium score greater than 100 to statin versus no statin, talk about ethics, we didn't think it was ethical or sensible to randomize people with a calcium score greater than 100 to a placebo, because we already have guidelines that say if calcium score is greater than 100, you should put them on a statin. And because at the end of the day, all we would prove is if you follow the guidelines, patients do better. So what we decided to do was to notify the patient and the patient's clinician about the presence of calcium on a CT scan that they had already had done some years before, perhaps, and some could be, 5 or 10 years, and not notify the other half. So we randomly assigned people to be notified or not notified. And that notification included an image of their own coronary calcium so that they could see their atherosclerosis. And it was accompanied by a message saying, the guidelines say, you should have a shared decision-making encounter with your patient to talk about getting on a statin and other risk factor intervention. And patient, you should contact your doctor to talk about getting on a statin and take care of other risk factors. So we worked it from both sides. And our primary endpoint was statin use, or statin prescription, by 6 months. I thought that we would get a really high, my expectation was 70% of patients would get started on a statin. And experts in the field said, you're crazy, 20% if you're lucky. So at 6 months, 50% of patients who were notified were on a statin. And at 18 months, 95% of those who were started on a statin were still on lipid-lowering therapy, which is unbelievable, because in primary prevention, these are people without coronary disease who are not on a statin. In primary prevention, half the people you prescribe a statin to are off of it within a year. Well, I think it's because of the image. I'm sensitive to the time. I don't want to keep you, but yeah, that's our story.
But you were asking about when will this get on the scanner, for example, automatically, right? I just want to point out in 2000, I was leading AI for GE, and we put it as a concept for a 2015 scanner to do all of what you said automatically. Now it's 2025 and I don't see that out there. So
let's make it happen.
Let's get it going.
Okay, great.
So
we're out of time, so I think, should we continue or?
Maybe one
quick
more comment. Thank
Maybe
you.
one more quick comment,
Um,
20 seconds.
I realize I'm the only European in this panel. I think it is important to realize that a lot of what we've been discussing and how the perspective is really from an American perspective. Because in Europe, we're facing still a lot of, well, let's say skepticism to even start lung cancer screening in a number of countries, let alone adding more like calcium scoring. So I think we're gonna have a bit of more an uphill battle there. And I think I'm very impressed with the way that in the US, this primary prevention and preventive cardiology is already including calcium scoring. So kudos.
We'll get there together.
Thank you, everyone. So we're now going to have a 15-minute coffee break.